Yeah, no, it's fine.
Yeah?
Yeah.
Yeah, we can.
Yeah.
Let's go. Wait a bit, yes, the blue thing.
Okay. SABC and someone else. Okay.
Who's there? Social justice.
Our gene expert.
Come stand here. Okay. Rather, let's try. You stand here. She stands here. Come.
I can't do more to come here.
So, Minister, these machines are gene experts. In a few weeks' time, we'll be able to do testing on these machines. We're just waiting to validate the test kits. The machines are state of the art. They'll be able to produce the results in 45 minutes. More importantly, also, in the future, we'll be able to do testing for TB. We've got all the computers are all linked through to our lab information system. So we'll be able to capture the patient's information here immediately, and then it gets directly onto our lab information system. So state of the art, we've got printers here. We will have nurses inside these stations. That's to prevent splashes onto your face.
Let's allow others as well.
So you can take a picture of the minister. Disposable gowns, masks, we'll have all the PPP that's required.
What you're seeing now is the minister being taken through the specialized equipment which will be part of these mobile units that will go to the various parts of the country. He's just being briefed on the kind of specialist equipment that will be in these units, that will be screening and testing all the different people around the country. As the President had said, it is just to test as many people as possible. There you see the MEC, Gauteng Health, MEC Bandile Masuku also, sanitizing. This is what the specialized mobile units will be having. There you see the minister also washing hands again. This has been a crucial message throughout this campaign. Washing hands and sanitizing. They've just been taken through the kind of equipment which will be in these mobile units. There's a lot of media trying to get these pictures, so it's a scramble to get these pictures to you. We were one of the first teams that were allowed to go into this particular unit. It's one of 60 that will be deployed to the different municipalities, particularly rural villages where this testing will take place.
Eh? Yeah, where? I get something to do.
We're just going to get some comment now from the MEC and the minister.
Not yet. It's just for pictures.
We are told this is just a session to take pictures. The press briefing will take place in the room where we set up, which is across the road. This is just a session to give the media an insight into what these units have. We are going now to a second unit. As you can see, a lot of media wanting to get in there, and we're hoping we'll be one of the first to bring you those visuals.
Step back, please.
This vehicle was rapidly built within 1 day to be deployed for screening and swabbing in communities. Okay. So what we're doing, we're keeping, there's a fridge. All the samples will be stored in the fridge and taken directly to the closest testing laboratory.
So let's just open the fridge up. So it will be stored, it can be stored up to minus 20, 26. Okay, and we've got a table with chairs, and we'll show you in the other van, we've got the ability to put up tents as well.
After the announcement by the President to ramp up the efforts in...
So there you have it. This is one of the units where most of the swabs will be kept in. The Minister just being briefed on the kind of, the kind of equipment that's in here that will be, keeping those swabs after they have been tested. As you can see there now, the Minister and the MEC moving now to another mobile unit. As we can see, these units have different specialized equipment in it.
All will be equipped with a pop-up bio hood to handle all the samples inside until it gets into the cartridge. Once it's in the cartridge, it's safe to put into the Gene Smith machine. So this is a pop-up. Yeah.
You want to put your hands in, Minister?
It's the other side.
Yeah, you put the sample in. So when the sample is sealed, you put the sample in. Put the sample in. Once the sample is in, then you open up the sample. You handle the sample in a concealed environment.
Technologies that we use to ramp up the efforts, test and then make sure that the people that are found to be infected are treated.
The Minister just been taken here through more specialized equipment, and this is going to fast track a lot of the tests that will be done in these very remote villages, as these field workers will be going door to door. We understand that 10,000 field workers will be going into the field
And Minister, each one will be
get as many people tested as possible.
So also in this, you'll be able to segregate patients and keep them apart. So this
Not like the media.
I think that's it from this leg of the unveiling of these 60 specialized mobile units. We're off now to the briefing where the Minister will address the media.
Well, those live pictures coming from Sandringham here in Johannesburg. You see there, of course, the Health Minister, Dr. Zweli Mkhize, accompanied by the Gauteng Health MEC, Dr. Bandile Masuku, unveiling those 60 mobile units that will be sent to different municipalities and some of the districts as well, all in order to make sure that they are able to carry out the screening and the testing, as per, of course, you would recall the last address to the nation that President Cyril Ramaphosa had given, where he indicated there'd be 10,000 field workers who will be deployed. All of this to address the issue of the spread of the coronavirus in South Africa and to ascertain exactly how many people may have contracted the virus in the country at this stage. You saw there some of the visuals, some of the specialized equipment inside, including fridges, where some of these samples will be stored inside there. So a move certainly that South Africa is taking to ensure that it is able to deal with the spread of the coronavirus and test as many people as possible. So we're expecting a media briefing in the next few moments to be addressed there by the Health Minister, Dr. Zweli Mkhize. We'll certainly take you back live to Sandringham in just a moment, but let's move on to other stories for now.
gained in the process. And amongst the top leaders who the whole country and the global scientific community respects was Professor RAMJEE. Still in a prime, really, when we expected a lot, we really are feeling very saddened and robbed by untimely passing away. We therefore wish, as I said, to convey condolences to all the friends and colleagues, and may her soul rest in peace. If I may just ask us to focus on the today's issue. Those of you who might have been with me around would know that I always have this clearing of the throat. Now, I must just tell you that I come from an atopic family, so we're a family that's got all sorts of sinus problems, asthma, skin reactions, and so on. So once you change temperature and your air cons and so on, it creates a bit of a challenge. However, we did test for COVID-19 and it's negative. It's negative. I think that's not for recording, that's just for information. Today we want to report that the total number of patients of positive tests that we have up to date was 1,380, which is an increase of 27 cases from yesterday's announcement. Which means that in Gauteng we've got 645, in the Western Cape we've got 326, KwaZulu-Natal we've got 186, Free State we've got 76, Northwest 9, Northern Cape 7, Eastern Cape 15, Mpumalanga remains at 12, and Limpopo remains at 14. And to date, we should indicate that 44,202 people have been tested, largely in the private laboratories, but that's equal to 47,541 tests. In other words, there are patients tested and number of tests, which means the tests are more because we repeated some of them. Of which just over 6,000 were performed in the public National Health Laboratory Services. This, for us, is way too few for the size of population and the inequality, poverty, and underlying burden of diseases and immune suppression that we have. So even though this number seems high, I'm saying it's still way too low for the kind of challenges that South Africa faces. So today we came to unveil a number of mobile laboratory tests, vans. The NHLS has procured 60 mobile vans in addition to the 7 that were currently being used, and therefore it brings us now to 67 mobile testing units in the vehicles which are equipped as laboratories. They will focus on sampling nasopharyngeal specimen for the PCR tests, which is what is happening in the laboratories. The current capacity of our laboratories has been pushed up to 5,000 tests in 24 hours in 10 laboratories countrywide. These mobile units that you have seen will also be used for the gene experts, machine equipment for PCR on coronavirus, using this equipment which is currently used for diagnosing tuberculosis. When these tests have been validated, and hopefully that should happen by next week, maybe end of next week, we are pushing quite a lot. And so, as I'm saying, hopefully next week, the NHLS knows that's a deadline that we are actually extending to them. That will move our capacity to about 30,000 tests in 24 hours. using approximately 180 testing sites throughout the country, consisting of 320 testing units. So some of the equipment that you saw that we said these were gene experts, that's what it will do. These mobile units will also be used for rapid test kits when these become available. They're not available yet, and again, having a 24-hour shifts to make sure that that becomes a reality. These will be focusing on people who will be tested in the community with the assistance of community health workers and also the contact tracers that will be that are out there in the community. And for the upscaling of this program, a list of priority districts will be finalized by MECs in a teleconference tonight. That will probably be around 9:30 or so when the teleconference happens. Just in case any of them might have missed it, at least you would get it from you that we are going to have a teleconference. But with the incidence of COVID-19 rising to more than 1,353, and of course we have heard the figure today, COVID outbreak has moved from an important traveler-based outbreak to local community transmission, where the Department of Health remain concerned that the lockdown will not be enough and that we need to ensure that COVID cases are identified. To achieve this strategy of increased case identification needs to be undertaken, that the President announced as the COVID home visit program. That is why we're announcing this today. The program includes, as we said, the deployment of community care healthcare workers to the field for door-to-door household screening, and each province has also been requested to start working on this strategy, deploying their own community healthcare workers, their professionals, as well as with appropriate PPE, personal protective equipment, so as to ensure, I think some of you would have seen how we've gone to the extent of protecting those staff that are going to be working on these units. The CSIR and the Right to Care have assisted us in mapping the most vulnerable population using some of the criteria, 993 strategic priority wards, which have been identified using Social Vulnerability Index. That is how they've actually identified the key wards, priority wards that we need to focus on. But what we'll be discussing with the MECs is to make sure that that identification is integrated with their own what we call hotspots, where they've already identified patients who are positive and contacts. Just to give you a sense of how I personally understand what is going on, I'll quote from you a letter that I sent to my colleagues this morning. So I sent this letter, which was a personal message to the colleagues, the MECs as colleagues and leaders in the fight to save our nation from probably the most devastating enemy that has ravaged many nations and destroyed many lives in recent times. And I sent the note to encourage them to be strong in the face of what may become the worst challenge that our country may face for generations. So I believe that if we're focused, we can actually collectively defeat COVID-19. We've seen a slower increase of COVID-19 positive cases in the past few days, and I'm sure all of you have been noticing that. I ascribe this reduction in the rate of increase to the following factors. Firstly, we closed the borders and reduced importation of the infection. A large number of infections were driven by people who had been to those particular areas that are already affected. Secondly, enforcing quarantine of the inbound travelers and returning citizens has slowed down the infection from traveling community to a resident community. It's been a very strong factor that. Thirdly, the lockdown has slowed internal transmission by reducing the risk of spread through large gatherings, churches, football and festivals and so on, and also overcrowded transport routes such as trains, buses, and taxis. However, we need to remain alert to a number of areas. We need more vigilance now more than before. The internal transmission, because of the following issues, the internal transmission internal transmission has started, and it may have a tendency to spread silently as people with less means and slight symptoms may be slow to seek medical help as they are few and far apart. Excuse me. So what it basically means is that those people who might be having mild symptoms, if they're in poor areas, they may not seek assistance immediately. But it's one person there, it's another one very far, so that means they're not actually going to be appearing as a big number of people, as it were. The second issue is that our testing criteria of patients with symptoms is reactive and restrictive. In other words, you have to show yourself up because you have now got infection. That's how we've been testing up to now. This means that we don't have yet a true picture of the size of the problem. We need to test hundreds of thousands of the population to get a better picture to refine our containment strategy. That's why I say even though we're talking about 47,000 tests, that's still far too low because of the nature of our country and the nature of the disease burden, the inequalities, as well as the population size that we're dealing with. This means that people with access to private family practitioners have largely tested, most of whom had the history of traveling into the Western capitals where there are challenges of this COVID-19 as an epicenter, and therefore they were easy to suspect if they've got symptoms, because everybody knows if you travel to those areas, even for slight symptoms, you need to come forth. The other thing, as I said, we need to be vigilant is that the lockdown may have the inadvertent effect of limiting access to health facilities for those who depend on the public services in poor and densely populated areas and other underserved communities because of transport difficulties. This means that the release of a lockdown may have a huge rebound effect on releasing every constraint that made the infection slow down. And we may have a runaway train with no way of applying brakes. That's the vigilance which we must put into the whole situation. Therefore, we need to engage all community leaders and call for volunteers in community and civil society formations to support the campaign against COVID-19, spread the message, and teach our people to take the containment measures more seriously and support all the affected individuals and families. The message of stay at home and the importance of hygiene must be made more emphatically. The message must be that COVID-19 is serious, but can be defeated. And we need each person to make this a personal fight to save our nation. Those on antiretroviral treatment and other chronic ailments need to stick strictly to their medication. Each person's action will count, because we have to break the chain of coronavirus infection. Next month, the flu season will start, thus making more people sick with similar symptoms, with no way of distinguishing common colds from an upsurge of COVID-19 infection. These will flood our hospitals and clinics, and create a fertile ground for coronavirus to spread or to be masked in its presentation. This means this small growth in numbers we may be currently experiencing the calm before a heavy and devastating storm. So, we need to be aware, that there may not be many further warnings before the pounding descends. So there will be no time to prepare what we have not already put in place. Particularly in the next 7 days, we need every plan to be put in place. So my plea to the colleagues, and as I was saying, this was a message I sent. My plea to the, to the colleagues was that, number one, setting up of the mobile units of health workers to move into communities with cases and contacts set up for testing and screening in communities, initially starting with the symptomatic and then extend to the greater community. So that means that these vehicles must go already to where we've identified what we call hotspots. And then we start with those who are symptomatic, and then we're going to move on to go to areas where we've identified contacts and positive cases. You have heard already that there were cases identified in Alexandra, Khayelitsha, in Inanda, in some of the townships in the Free State. So that's why we have to roll this out. When the President sent the message, it was because it is important for us to move ahead of the spread of the infection. We will now procure rapid test kits, taking into account any of the flaws that anyone may point out as we roll out the testing and surveillance and then start the isolation of patients and quarantine. The advantage of those is that you can actually test one person and get response and results very quickly, and then you can decide whether to extend to the family if you think that there's a need at that point. So we're hoping to get all of those. We have actually said our SAPRA must work 24 hours to make sure that we can get all the information so that these tests should then become available. They're not here yet, but they should be coming soon. But whilst they're not here yet, we actually have these particular tests that are going on now. In other words, rather than waiting for the patients to come to the hospital, we're now going to go out and look for and find the patient. That's the message of these vans going out. So we will be focusing on dismantling the infection cycle by proactive action than the reactive approach that we've adopted up to now. In other words, we're combining now, the initial strategy was a defensive strategy, where you get the patient attacked by the virus, then they report and then we test them. Now we're going to go on an offensive strategy, where we suspect where the virus could be. We find everyone and check if they've got the virus and deal with it before actually people even present themselves. So there must be very clearly defined district and sub-district level structures with a clear short command line, which is led by experienced professionals, which will take clinical decisions quickly on how to deal with the patients on the spot. So we need experienced leaders on the ground. Secondly, we need to procure additional beds and dedicated treatment centers where COVID-19 will be treated in every town. So every town now must begin to prepare for, in case we do get patients coming into in those particular areas. We also need to make sure we find more quarantine beds so that people who have got a situation under which they live, which is not possible to quarantine at home, they should actually be found into places where it's possible to be able to be quarantined. So we'll be getting reports tonight how far they are going. We're not necessarily going to be reporting that to the media, but this is just our normal approach. So every province now must identify health professionals who must be earmarked to focus on these COVID-19 teams. We will also be seeking reinforcement from some of the countries that might be able to assist. For example, we have approached the presidency to approach China and Cuba to actually assist with reinforcements. So hopefully those in the next couple of weeks, we should see some of them coming to reinforce. The advantage of China is that they've just gone through the same, so we'll actually be wanting to use that experience. But the advantage of Cuba is that their community and district health model is actually one that we'd like to use because it works for instances where you'd like to be able to reach out to many communities and ensure that there's a good cover at community level. So we're encouraging also, and this is the issue I want to discuss tonight, we're encouraging that the institutions should release from hospitals patients who might be easier to treat on outpatient basis. This will assist to reduce hospital loads, but at the same time will also reduce the risk of cross-infections. So we're going to also be encouraging, asking all the clinics and the hospitals to provide daily COVID-19 tally. Did they suspect any patient today? Did they get one diagnosed today? And talk about how to manage that so that we bring that as part of the daily management of our patients. So all the treatment and PPEs that's going to be needed for the next few weeks, we're asking that the departments, various provinces must try and procure so that we've got enough stock as we move forward. We are aware that there are challenges of the stock right across because everybody in the world is looking for the same stuff. So we've given allocations in terms of kind of guide in terms of provinces to say they need to increase and make sure that they've got capacity for so many thousands additional new beds so that we give them guidance on that. Those are some of the issues we'll be discussing tonight. I think based on the current observations, we actually think that we're seeing the mortality has started picking up, and therefore we think that the numbers, the numbers that we are seeing, we mustn't expect them to come down immediately. We must therefore make all the health workers to be focused on the fact that there's that pressure that we are seeing. We'll obviously look at the scientific models. There's quite a lot of modeling that we are doing, but we only deal with that when it comes. But at the moment, we're using basic observations in terms of what we see as a trend. So this, what I've just shared with you, is not all what you would have got from the models. It's just observations as we see the situation and therefore discussing amongst ourselves as the leaders in health and in government. So we are saying to everyone that everybody needs to move at a faster pace, because there's not much more time. We must just be ready for whatever then happens. As we say, we plan for the worst even if we hope for the best. And in this case, we're actually saying everyone needs to move on and make sure that we are able to give all the plans, start with the plans and making sure that they get implemented. So, but most of all, it's important to remain focused and to be courageous, because in the midst of any kind of crisis, the worst you want to see are leaders who are anxious and disorganized. In this case, we actually have to face up to the fact that this COVID-19 is rising in all the countries, and we can't see ourselves as different unless we do the basics that have made other countries to succeed. And therefore, we still want to send the message to our people all over the country that the message that has been sent by President Ramaphosa about people staying at home is still very important. The message of ensuring good hygiene is still very important. The message of social distancing still remains important. The message of making everybody understand that this is a problem for everybody. Any kind of thinking that if you is for the rich people or for the poor people is misled. That one is misled. If anybody thinks there's a disease for the black people and not the white people, or not for it's for the white people and not the black people, again, those are misled. Those who think that it's a disease you'll only find in township, informal settlements, and not in suburbs, or the other way around, that you only got to get it in suburbs, again, those are misled. This disease can be anywhere, and it can get anybody, and therefore it's important for us to face up to the reality that we can be able to defeat this infection if we work together. If you look at the history of the various countries, as I was saying yesterday, the history of China is very, very encouraging. They were like the West in the world. They are now the number 4 and slowly getting to be less and less of the important epicenters of the infection. If you look at South Korea, they were number 2 at the beginning. They are right down at number 13. But America was nowhere. When China was running around 50,000, America was somewhere. They probably got about 176 cases. That was about a month and 2 weeks ago. But the number now has gone to over 120,000. That means it is not necessarily the infection and the conduct of the COVID-19 that matters. It is the conduct of the community, whether we can be united, whether we can follow the guidelines, whether we can work together, whether we can be focused in dealing with this issue. And I think, therefore, the message that goes to everybody is that we need to take the issue seriously. Not that we must panic, but it means we must not be complacent. So as we look around, we do expect people to be staying at home. Just go out for the essentials, go out and get the basic necessities, the food, and so on. Because, of course, the one thing we wouldn't like to see, people can't save themselves from COVID-19 and still die of hunger. So it's important for us, as President has said, we must allow the food supplies to be allowed through. All of these are important for our people. But we must be able to use the 3 weeks that has been allocated for a lockdown. And I want to say that there is possibly an impact, but the impact is not irreversible. The impact is also not actually at the point where we can say we have now dealt with the infection. It means that there are things we can do to change the course, but it's too early to say. And therefore, we mustn't be misled. We must still remain vigilant. We need to understand that for the situation turn the other way, we may not get any other warning. So whatever warning we've got now is important, is enough, but we can still fight this infection and defeat it. It depends on us. It doesn't depend on COVID-19. It doesn't depend on coronavirus. It depends on what South Africans as a nation can do. Thank you very much.
Yes, indeed, a round of applause. It is all up to us. Every single South African can make a contribution towards this fight towards COVID-19. I'm going to ask Dr. Masuga if you would like an opportunity, or has Minister covered you completely? Okay. Dr. Kamichuti, you're not going to make any comments? Okay. Right, so that then brings us to the question-answer sessions. We'll take rounds of 5 at a time, please. I had a hand up here. I had number 2, 3, 4, 5 with newsroom. So we'll start here and then we'll come around. We'll come to newsroom and then we'll come to this side. Okay. So I think let's take the rounds of questions, and then whoever is going to answer those specific questions will come to the podium at that particular time. Okay. Number 1.
Sorry, it's Anthony Squazine from Bloomberg. This screening program that you're doing, has it been done in other countries? And if so, which ones, and who's giving South Africa assistance?
Thank you. Chair.
Hi, EWN. Minister, when you say you want to integrate areas that are focused, local districts and also hotspots, have you identified any of those districts or hotspots that you want to focus on? And number 2, when you say lessons must be taken from China. Are you in communication with them on how those lessons can be implemented in South Africa? Because I don't think it's a paste and cut and paste situation because of different structures of government in this country, and also how special planning is. And the last one is in terms of when you say the calm before the storm, have you noticed any patterns to support that, saying that there might be, because the numbers now might increase as we come into the flu season? Thank you.
Number three number three.
Minister, my name is Tekana Mkhize from Mutual Africa. Just a simple one. The healthcare workers working on the ground, what kind of measures do you have in place to ensure that strategy is not hijacked by criminals? It could be an easy way for criminals to knock on people's doors and say they're from the Department of Health.
Thank you. We'll actually take all three questions on this side.
TRT World. Minister, if you could talk about stigma, it's something that I've spoken about before. Stigma, yes. I was in Alexandra, Australia, where there was some testing, and talking to community members, there's still jitters, people saying that, I don't want to test, I don't want to be known as that guy that, has a coronavirus. Even after somebody would have been taken into isolation, comes back to the community, having tested negative, people don't want to be seen as that person that, somebody doesn't want to interact with, or just even straight that within Alex known as that person. How important it is that we don't do that as communities, and why it would be dangerous for us as a country to, stigmatize one another.
Thank you. There was another question over here.
Minister, if I could ask you to address a little in more detail about myth busting, some of the incorrect rumors about who it affects, who it doesn't affect, immunity to it, myth busting, dispelling incorrect information.
Thank you. There was not another question here? All right, we'll wrap it for now with those questions, Minister.
Thank you, Dr. Manzi. I'm going to try and assist in answering some easy questions, then I'll leave the difficult ones to the Minister. I think it's true that we are looking at different countries in terms of how screening will be done. But also we are looking at the lessons that we had from how we started off when we did the HIV rollout. You would remember that when we started off with no rapid tests in terms of screening, but when we ended up our rapid test being the ultimate, in terms of even giving diagnosis. So there are countries that have done it. We're reading a lot about what South Korea have done. I think currently South Korea is one of the countries that have done a number of tests more than any other country in the world. And they've used their own way of how they do it. But for us, we'll still have to remain a bit logical and rational in terms of approaching hotspots, identifying hotspots. And identifying hotspots means that we'll have to deal with a number of contacts in terms of one area of close density, and then we'll be able to do the test so that we're able to do proper testing. I think the main focus point is to start with those who are high risk and then go to those who are actually of lower risk. So yes, we are reading from other countries, and we are actually getting a number of lessons. And I think one thing, the issue that we also have to know is that we are not going to have a South Korean model that will be implemented in South Africa, or a Chinese model that will be implemented in South Africa. The only thing is that we have to combine and create a South African response, which will be relevant to our own conditions. Because I don't think South Korea, they have an area that looks like Alexander or Diepsloot or Zandspruit. So we'll have to come up with ways and means, just taking the lessons from those countries and also learning from what we did when we started off with the issue of HIV and AIDS testing. And we are going to use that type of thing. And we have not finalized how the testing will be done in terms of, because again, we need to clarify the whole thing to also agree that when we increase our sensitivity on screening, remember currently we use your history of traveling, your exposure to somebody who has been infected, and we also use that's from history, the symptoms, and then thirdly, the issue of fever, which is a high temperature. And now if we include the rapid test, it's going to increase our uptake and it's going to make it easier for us to make simple decisions at the time and at the point when we see the patients. So it's important that we also clarify that for screening and testing also there is a major difference between the two. And I think we need to be clearer on it in that space. The issue of health workers, it's a big concern. You know, I think you have realized that now even the minister and the ministry, the issue of tracing and tracking health workers who are positive, it becomes one of our preoccupation. But joined to that, coupled with that, is that we also linking up with the acquisition of proper protective, personal protective equipment to make sure that it's correctly used and it's correctly used at different points. Because we also have to mention, I'll mention this, that there's no way that we can be able to provide for a person who's not taking care of an infected person or triaging. So we also need to educate our health workers on the type of PPE that they have to use and when, so that we are able to use them judiciously and be able to be cost effective, because we also feel that as a global phenomenon on shortage, we have to be very clear on how we able to distribute the PPE. We have already started, Minister, in Gauteng, where we are able to measure the stocks, and able to give the individual worker an ability to report if there's something that is missing in a clinic. So that is, we don't rely only on officials and managers, but also to get direct reports from health workers. That's the only way that we can also empower our workers, our health workers, to make sure that they are, they are protected. But it's our preoccupation. I think the minister makes sure that every time when we report, we also have to report on our stocks that we are having. We have already also, waiting for stock from other things. I think that's the weakness of our economy, that most of the PPE that we have, we do import. So it's one of the weaknesses but I think going forward, as I've said before, that we are taking this pandemic, the fight on the pandemic, as an opportunity to build a number of capacities that are not there in the country today. So in future, when we have started this process during this fight of the pandemic. Stigmatization is a big problem. I think when I went to see our first patient in Gauteng, she was pretty much worried for being identified, because of fear of being stigmatized, and she's a person who owns a small business, and also it was going to affect her business if she was also announced. But I think ethically, as doctors, as medical practitioners, it's also important that we maintain an element of privacy, an element of confidentiality in terms of who we disclose results to. And it's something that we need to be clear. The issue of myth busters. So the stigmatization, the only thing is to make sure that we continue educating our public that ultimately when you are found to be COVID positive doesn't equals to death and doesn't equals to anything else that is actually with a negative image. But it's something that ultimately we will have to take it for. That we, as a country, have started off with HIV. So I'll always refer to HIV because that's where we have to draw the lessons on the future fight, so that we don't start like as if it's the new thing that we are doing, but it's something that we are building up and improving as we go on. Mythbusters, we have to. I think we owe it to ourselves that we have to do, particularly provide facts. Provide facts and maybe stay away from our own individual opinions as leaders and as politicians, and just stick to scientific facts. If we do that and all the time, it will be much easier to deal with myth, because a virus, there's no virus that chooses class, chooses race, chooses religion. A virus affects every human being, and every human being that has got those actual receptors. So it's an important thing that we have to do, that we just have to stick to the science and stick to actually the facts, and it's a thing that we'll do. So I would say, Minister, and the general public, that there are a number of things that we will do that will improve on, and yes, some of them that there will be new ways, the new models that we are doing as South Africa, but we are hoping that it will be better. And the camp before the storm, I think, of course, we are going to a winter season. So that's why it's important, if you've got your own medical insurance, it will be important just get a jab for a flu vaccine. We are prioritizing the most vulnerable groups, your elderly, your pregnant women, your children, and those who are living with HIV and TB, just to make sure that we exclude a larger population of people who are vulnerable and be able to deal with those who are healthy. And I think those are the most easy questions, and the Minister will deal with the difficult ones. Thank you.
Thanks very much. The Minister wanted me to just highlight some of the equipment that we have in our laboratories. We have procured state-of-the-art equipment, and one of the machines that we're using is a biorad machine that's got an automatic extractor of the virus, and this is in the facilities that the Minister has mentioned. Over and above that, we also got the state-of-the-art Cobus 6800, 8800, which has just recently been approved by the FDA. We're validating the test kits, and we'll be able to use that machine. The gene expert itself that the Minister has mentioned, and you've seen in the vehicles, will be able to do the test in 45 minutes. Now, that's really going to be a change agent for the tests. So with regard to screening, we have looked at other countries, and what we want to do is we don't want to follow, we want to lead. We've got the biggest viral load program and gene expert program at TB, and so we can show the rest of the world how we can do it. Thank you.
Well, as you can see, I'm only standing up just to make sure you don't feel I've disrespected you. But my colleagues here have answered all the questions. Let me start with the last one that Dr. Chetty has just given. Many countries have used the PCR, which is basically using the nasopharyngeal swab for the tests. There are many countries, well, then there's another test, which is the rapid test kit, which is more the immunoglobulin detection. It detects immunoglobulin G, immunoglobulin M, and these are being done in a number of countries, but they have not been generally been accepted, endorsed by WHO, but a number of countries have actually used them to good effect, and we have actually been right now going through evaluating those countries that have actually had the proper submissions and are already using them and registered them. So we'll actually go to those countries, make a negotiated arrangement, and get those rapid test kits to come over. The PCR, in terms of the gene expert, is actually just a conversion of the same technology which we are using for tuberculosis. So that creates an unusual pool of gene expert equipment in the country, because we have got the highest burden on TB. So we want to turn all of these disadvantages to an advantage of actually having the combination of testing capabilities that don't necessarily exist in any other part of the world. And therefore, what Dr. Chetty is saying, that we don't necessarily need to follow what has happened, we just need to look at the basic principles that are associated with the process. Yes, indeed, it's generally accepted that wide testing is important. This reactive approach has got its place, but once you've got to a particular point, it's important for us to be leading ahead of the infection. So you need to go and discover people who haven't got infection so that you may find out as many of those who might be having the infection. That's the only way you can stop it. In other words, if you're a farmer who would be saying you are actually seeing the fire that is coming up, instead of worrying about trying to take down all the flames that are now raging or are going to rage when the wind turns, you actually go into the front and actually create a fire break, and then you can push the fire back, and as they say, fighting fire with fire. If you're dealing with it from a military kind of combat approach, basically we are saying that a defensive approach, you basically get attacked by the enemy, you go look for the enemy and try and deal with it and deal with the casualties. In an offensive approach, you actually have to move ahead to discover where the enemy might be and then find the enemy, deal with the enemy before it actually affects your people. So whatever approach you want to take, we've seen how this has worked. We spoke about the case of Venice in Italy, where they actually they moved from wall to wall to deal with the issue of testing, and they say that it did make an impact. South Korea, one of the major attributes of it is now today is about country number 15. It was raging at the beginning. So we think that there are good lessons to learn. There's an article which has actually been published, and we're going through it with a lot of colleagues overnight, that comes from the US, which points out what delays could have actually affected America. We're not sure whether the truth is, but it's got lots of very interesting lessons which we are learning from, to say there are things that you need to actually decide earlier on. Amongst those is to reduce the academic debates. You get a broad consensus of what works, what helps, and then use that. Whilst we've got space for discussions, for debates, and so on, that must help you to be able to find new answers. But on what has been proven, you must start implementing. Don't wait until you've got the best solution. And as I said to my colleagues, there is no perfect plan in a battle. The only plan that is working is the one that you test on the battlefront. If it's got problems, quickly discover, change tack, and move on. In this case, we don't have time to waste. We have to actually move. Whatever the weaknesses might be in what we're doing, we'll understand that, but all we're saying is that that's all we've got, to try and reach out to as many people as possible to try and get them to be tested. So we're unfolding that kind of process. This is the right time to do it when we're dealing with the lockdown and everyone is at home, and the rate of the spread of infection is kind of being arrested slowly, and therefore we're saying let's go over and try and identify where the real infection is. When we know what is the prevalence of the infection, we know how many people are likely to be infected, we'll be in a better position. When we know which areas, which geographic locations have got a larger infection, then we'll know. When we know which people are more vulnerable, excuse me, which are more vulnerable, all along we knew it was imported cases. So we've dealt with that. Not that we've finished it. We're still discovering people who are visitors, are tourists who are still positive, and so on and so on. You still get a lot of transmission from someone who's been to those areas and those who have not been. But we're going to get to a point where there'll be people who have got no history of knowing anybody who's got an infection, no history of having traveled abroad, no history of ever knowing anything about COVID-19, and they'll actually be needing to be treated. So we are preparing for that kind of situation. So we take lessons, but we think that this disease is so new that not everybody can say they know everything about it. Maybe from some of our mistakes and our successes, we might be able to share something to the rest of the world. You did hear in the last few days, we did indicate that we've got 10 of our universities and 30 of our top scientists who are going to be part of the research work. So we're actually using all fronts to be able to look at how we deal with this problem. So did we contact China? Indeed. We in contact with China, but last week on Thursday, we were actually part of a whole communication by WHO where all the ministers of health in the whole world were actually taking presentations from China, from Singapore, from Korea, from Japan, what were the lessons from there. We sat through that and we picked up a lot of very important lessons. One of the lessons which was important, which we thought was very much worth, two lessons that I think are important to highlight. One is early testing and early identification of those who might be affected, and early quarantine or isolation. That's one very important issue. The second one is take your people along. Transparency, make sure that you are as open as possible and share the information, because this is no longer a professionals' fight. It's no longer a fight of the doctors and the professors and the researchers. It's the fight of the community. For them to be able to deal with the fight, they need to have the full facts and be armed with facts. And so the question of demystification or demythification or debunking the myths is actually about saying we will only fight coronavirus with facts, not fake news. And therefore it's important to say we'll be led by those who understand, who have researched it, who will tell us this is the way we go and we must follow. And I accept what MEC has said about it. On Friday, we will have a conference call with all the MECs and the whole total of scientists who are part of the Ministerial Advisory Committee, which are the clinicians, the researchers, the virologists, the epidemiologists, and social scientists, and so on, together with MECs and heads of department of various provinces. We'll actually be having experts from China will be connected through a telecom conference or video conference. We'll be asking them all the questions that any one of us would like to ask. So we will be actually using their experience to check, to discover what is it that they can assist us with. When we have any of those experts coming through to South Africa, we hope it's going to be soon. They'll actually be helping us to say this is what they found to be useful. So the approach of what we're talking about is really based on saying that there's experience all over the world. There are successes, there are failures, and both of them give us lessons. Then I think the issue of stigma has been raised. I think it's important for us to always be out there to make people understand that this infection will affect anybody. If it has not affected you now, it may still come in the future. So there's no point in actually anybody being destigmatized. It happens if the disease is new, when people panic, when people fear, they become a lot of anxiety. We went in Limpopo, there were some people who were complaining that, we're bringing coronavirus to Limpopo. When we sat down and we explained, everybody, no. We actually didn't understand it like that. Now we are welcoming all those people who came from Wuhan. And at the end, it was more the information that helped us to be able to get them to get out of the fear that and the anxiety that they had. So, yes, the point, we're not making exaggeration when we're saying it's a calm before the storm. The basis on which we are seeing the numbers moving the way they're doing is actually based on the particular conditions which you can see. And we're saying, if you actually let go of those conditions, and then there's a winter flu season, cold season coming, you may get a very different issue wherein what we are seeing now can actually be immediately reversed. And so we're just saying there must be alertness, vigilance amongst our people. Not fear, not anxiety, alertness and courage, because that's what will actually make us to be able to fight the infection. So, yes, excuse me, yes, the issue is that we must not be complacent. We can't turn around and say, you only saw 27 new infections reported. No. There's still a lot more that's going on there that we must go out and discover. And even when we have discovered it, just remember the virus has no boundaries. Doesn't mean that if you have dealt with it now, it can't continue, it can't come back. You know, China is battling a new wave, both China and South Korea. They contained an internal transmission. They're now dealing with re-importation of the cases. So with us, we've got the same, because we've got both of them, importation as well as internal transmission. So if any of those two become a challenge, it means that we'll even have a bigger problem. We've just held it temporarily because of some of the decisions that have been taken by government to actually create a lockdown, restrict movement, and so on and so on. So we must be aware that it is not just simply because we're now fine, we're South Africans, we can get over this thing, and that's it. It won't affect us like it would have affected other countries. So we must realize we're not different from any other countries, but we can be different in the way that we learn from that, the lessons from other countries, and therefore we're able to deal with the issue differently. We'll do everything to make sure that our workers, health workers, are protected. We'll also be working on creating a visible identity for some of our health workers so that it's easy to identify. But really, we want to call on any kind of criminal elements not to play into this space, not to really try and misrepresent health workers and create an impression that they are actually coming to assist people, because it's actually inhumane to do that. But we are not going to stop sending people out there. We just need to make sure that we work together with the community leadership, work together with the communities, civil society formations, just to make sure that people are protected from any charlatans and criminals. I think maybe I should leave it at that. I think we've really covered most of the questions that you raised. Thank you very much.
Thank you very much, Minister. I do realize Minister does need to leave for the meeting. Minister, are we able to take one or two more questions? It will be the last round. The very last round. And while you're thinking about those questions, Professor Buch just indicated, okay, at the end of it, then we'll give Professor Buch a chance. So we have, there's quite a lot of hands. Colleagues, may I just please request that we keep it very brief. We do need to let Minister go. He does have that meeting. So very brief questions, please. I see we're going to start that side because we only got one mic. So it's 1, 2, 3, 4. And then, I didn't miss anyone here. 1, 2, 3, 4, 5. All right. And then on this side, we have 1, 2, 3, 4, 5. Okay, we'll wrap it at that, please, colleagues. Thank you. We'll start that side. Oh, thank you.
Hi, good evening. It's Kylie here from EMCA. Minister, you said your approach is going to be proactive. So what other areas are you looking at, apart from upscaling the testing and other means? So what's going to be different from what you've been doing? But also just another question, Minister, regarding the issue whether in South Africa have the doctors been administering the malaria drug as one of the ways of treating the patients? Have we been doing that? And maybe just as the last one, Minister, have you been interacting with your counterpart from SADC region? What are they saying to you in light of most countries going on lockdown? Thank you.
Please, colleagues, one last request to please keep the questions brief. In fact, I think where there's 10 questions, 1 question each per colleague. Thank you.
Mr. Zweli from Sunday Times. There was an announcement today that the taxi industry has been given the go-ahead to operate at full capacity, provided that people are wearing masks. So I just want to check, considering the need for social distancing, is the move the correct one? Is wearing masks in taxis an effective measure to counter the virus? And also you did mention that there was a shortage of masks in the country, so if you can just touch on that and perhaps the effectiveness of wearing masks and gloves, if you just take us back to basic things.
Carl Young from News 24. Minister Mkhize, yesterday in Durban you touched very briefly on the issue of ventilators and efforts to procure more ventilators and also locally manufactured. Please can you expand on that? And is there a number of ventilators that we might need? Are you projecting any requirements in that regard? Thank you.
Hi Minister, it's Catherine Child from the Financial Mail. You're going to increase testing, you're going to go to places that are very crowded, like second-hand addicts, and you're going to find more cases, which is great. And you're going to hotspots. People live in crowded shacks and they live in crowded houses. If you find people who are positive and live with 8 other people, share a room with 3 other people, what then? If they're socially isolated home, they're going to spread the disease. Not everyone is middle class, not everyone has their own room. What are you going to do with the hundreds of people that you find who test positive, who literally cannot isolate in a shack?
Thank you. We're moving. That was 5 questions that side. We're this side. Thank you.
Minister Ahmed Kazi from Eyewitness News. One question was covered. Secondly, could I just get confirmation on the total death toll, please? Yeah, death toll. Okay.
Hi, Minister Zweli from the I have a question about the labs that are currently testing for COVID-19. What is the backlog? The backlog at labs that are currently testing for COVID-19.
Thanks, please go ahead.
So, Elmer Schutz, Spotlight News, just jumping on the back of Carl's question of how many ventilators. Could you please also tell us where you're experiencing or expecting shortages?
Thank you. I believe I did miss number 5, that side from Newsroom Africa. He's got a microphone. My apologies. Go ahead, please, colleague.
Minister again from Newsroom Africa. With your talk of ensuring that there's vigilance and more alertness going into the winter season and the flu season, are we likely to see a lot more aggressive measures taken to flatten the curve? And would that entail increasing the days of the lockdown?
Okay. 2 very quick questions this side.
Good evening, my name is Jean-Philippe Remy. I'm a journalist with Le Monde. I'd like to know how many beds of hospital are currently available in South Africa, both on the private and public sector, and to which extent you're trying to augment the capacity of these beds in general. I understand there's new facilities which are organized at the moment. Which kind of figure are you looking for?
Last question from SABC, then we wrap, please, colleagues. Okay.
Minister Zweli Mkhize from SABC TV News. You said the calm before the storm. What's the worst case scenario that we are preparing for as a country?
Thank you, colleagues. That will be the last question.
Okay, thank you again. I'll take the easy ones. I think we've been doing a lot of, I think Minister spoke about the modeling that we are doing, and in terms that influence our planning in terms of resource allocation and everything. So we are almost calculating and planning for the worst case scenario, and I don't think there would be any point beyond that unless we talk about the catastrophic scenario. We all know that in terms of what we have learned in all the countries, that 80% of the people who are infected will normally have mild infections. And I think the science has held truth actually to that fact in most of the countries, particularly in countries where they started earlier with their containment measures, which I think as South Africa, we believe that we did that quite early. So we are expecting that we will be not having a very high peak of infections because of the measures that we've done. We have not yet started to celebrate, but it has indicated in terms of the recent times that we are now reporting very fewer new infections. And it's something that we're hoping that it will be sustained. And hopefully it will also help us to, after the measures, the restriction measures, we are not going to just simply kickstart everything. I think we'll have to gradually introduce life back as it's supposed to be normal, so that we sustain the element of flattening the curve a bit further. And certainly knowing that the whole purpose of flattening the curve is just also to make sure that we reduce everything to the capacity of the state. And I think the minister will cover essentially the issue of the bed numbers, but we are calculating the bed numbers in terms of that modeling. 80% of the people we will have, we start with 60% of the population will get the infection, 80% of them will have mild infections, 20% of them might require hospitalization, less than 5% might require ICU. And when you look at that modeling, you will see how the numbers actually get determined. With Gauteng specifically, I will tell you that we will require close to 1,500 beds for ICU, because we know that the majority of the people, we might be able to treat them outside a hospital facility, and it's what we're using. So we have to, the science actually still holds in many instances that we're using, and also in terms of the modeling. So even the numbers of the beds that will be required. We are looking at facilities, like we are having facilities that have been made available from our state-owned enterprises, where we can be able to isolate individuals who are found to be positive in communities who cannot self-isolate, because I think we are working towards making sure that we don't have that period of quarantining when we get our rapid test and we get our testing properly done. That period where people are uncertain might be very shortened and will reduce the numbers. We'll only deal with those who require hospitalization and who require isolation. And that's what we are actually looking at. So those facilities are available for those type of communities who can't self-isolate. And we have been on the fortunate side of things currently that most of the patients that we have had have been able to self-isolate and self-quarantine going forward. And the issue of the masks, academics have got a very big tendency of debating amongst themselves, So usually our Alt-Delete, Control-Alt-Delete, our default position always will be the World Health Organization advice on the usage of masks. But like we've said, that we'll adapt everything that will work for us. There are people who are of an opinion in areas of high density, high vulnerability, with high numbers of contacts, that a mask might be useful in that type of situation. But in general sense, we know that masks, as they are used, let me not say anything, but as they are used currently, they might not be that useful, because even how you take it out, how you take it on, there's a lot of things. So it might be more dangerous to even wear a mask, even if you're trying to protect yourself, So it's a big discussion. I think the minister will also cover it from the national point of view. But we just want to say our default position every time will always remain the World Health Organization guidance, that those who are symptomatic, those who are sick, those who are taking care of people who are infected, they should actually use a mask. And it doesn't mean that in 30 days' time, when the situation changes and we are learning new facts and new things, we might not revert back to the general view about the general usage of the mask. The major ethical point is that, would you imagine a situation where the general population have got masks, but the health workers don't? So we need to also answer ourselves in our mind that we also have to have a way on how we ration out the resources that we have. So we would want to keep the most of our PPEs for the health workers, those who will generally want, who will be able to treat, the patients. And the issue of clinicians and what we have been using, we have been in discussion. Like we had a mini discussion with the clinician who was taking care of our patient who passed on over the weekend, the condolences to the family, that what are the means that, what was the issue around the form of treatment and what did they institute. We had a patient also in Gauteng who was in ICU, who's now actually a minister home, who we thought that he's not going to make it. He had renal failure and had a lot of issues. Went to ICU, came out, and is doing well. So we had also a discussion with them on what form of treatment that they have. We are part of a broader World Health Organization trial known as Solidarity, which is actually looking at 5 arms of treatment that have been tried throughout the other countries. You know, there's the one of chloroquine, there's one on the antiretroviral drugs that we have, there's a new drug that is novel, that is not yet licensed, but it's created and it's manufactured as a drug that will treat coronavirus and all the others forms. So we are part of it, and we are learning, and we hope that the whole information that we are gathering will also help the whole world going forward, and also our countries in the SADC region. And maybe lastly, it will be that, you know, sometimes there are people who say that we must maybe more often now, Minister, pronouncedly talk about recovery rates, because we have been all the time talking about infections, and maybe now we should be at a point where we talk about the numbers of people who have recovered, who have been discharged home, who have been treated at home, who didn't require any form of hospitalization. And that will also be part of our fight against the myth, you know, where people equate being infected and death, you know. So I think that the death toll might be something that we must not mention quite often, but the minister will give us the numbers, the recent ones. But I think the major numbers that we need to talk about, which is the majority of the patients, is the recovery, ones that have walked home and who are actually quite well. And I think that's the issues that we need to try to work on. The weakness of our economy is just that we are a country that relies on imports, you know, and ventilators will be a big problem. But we are in a space where we can be able to utilize the beds that are there. We have our own ventilators in the public sector. We actually even discovered in some aspects ventilators that were bought like 5 years ago, never used, put up in the storeroom. So now it helps us to even take out those machines and create our own capacity. You know, there are hospitals that, like Tshwane district in Gauteng, now it's almost all the 200, 300 beds in Tshwane district that are there are almost confidently say that they are dedicated to COVID-19. And we are going to build some temporary trial facilities when the need arise to increase our bed capacity. So we are quite confident that flattening the curve, we will be within our means in terms of resources, but we just need to continuously strengthen those measures to flatten the curve. Thank you.
So with regard to the backlog of tests, I can state that there is no backlog of tests within the National Health Laboratory Service, the NHLS. And I also spoke to the CEOs of the private laboratories. They have no backlogs of tests. Last week sometime, one of the private laboratories did have a backlog, and we rallied together as the private sector and the public sector, and we split that backlog between the NHLS and private labs. So we've cleared the backlog, and as of now, there is no backlog. Thanks.
Thank you. Just to confirm again that we have an open line with all the CEOs of all the private laboratories. Last week there was a backlog, it was 6,500, and the private labs indicated that there was a pressure at that time, and we actually made sure that there was good cooperation between the public sector and private sector. The following day, we cleared all of them. There were about 4,200 specimens at the time when we discussed. It was collaboration. So every day now we watch the space to see if there's any backlog. As Dr. Kemi Chetty has indicated, if there's any backlog, the private sector is always welcome to indicate so that we can actually take over some of the specimens and do them. At the end of the day, the specimens are not about one laboratory, they're about the whole country. We want to be able to deal with it. So from that point of view, we can say that we do know that there are no big challenges. Well, somebody asked, I'm not sure, somebody asked what is different. We've just outlined the whole thing that's different. All the tests that we're doing that were not being done before, that's different. And I think, well, you know, I'm sure there must then be some things that we need to find out more. But what we're doing is completely different. It's not the way that we've been dealing with the situation. And so that's what is different. I think when we're saying that the approach is proactive to go out to actually reach out to the areas. We've not before been going out to target communities. Now that's what's happening. We've not before had as many as the 67 vehicles that we have had. That's something new. When I'm saying that there's going to be new kits that we're bringing in, fast-tracking the registration, that's different. I think when we talk about this, we can see what is different. I think we hope that we all ultimately see that there's something else that we've tried. The questions of SADC, we are in touch. We talk every now and again with different ministers. Basically, I think everyone is trying to manage the situation in their own countries. Sometimes there will be those that might be asking for assistance. As we speak here today, I think what's important is to know that we still have our NICT as a reference laboratory that remains available for the rest of the continent where there is need that they'll be utilized. I think it should just be recommended that we use the masks whenever you feel you need to. Those who are symptomatic, even those, if you are particularly in overcrowded spaces, that might be helpful. I think the point that have been raised by MEC are important. There are certain precautions you must always take with the mask. And so even with the taxis, we encourage that. We should do that. But it's early days. We're trying to help. And I hope we can actually be taken with that kind of understanding that we're trying to help and to improve the situation. Now, each time you try something, sometimes you get questions that makes you wonder whether, in fact, the motive is understood as what we're trying to do at that level. So we will be assisting where we can. People must continue to try and ensure that there's good social distance. Sometimes it's not possible, so you might need to use masks, and sometimes that becomes a challenge. We'll keep trying to increase the numbers of masks available. It's a difficulty, I think, in many countries, so it's something that we have to work on. The point has been made about the overcrowded instances. Those who may not be able to self-isolate, then we want to be able to assist them, to move them somewhere where this can be possible. So that's the approach that we're going to be taking. Well, we didn't prepare details to be able to brief you on the deaths as we speak. We did indicate yesterday the numbers. There are 2 that were reported, but we're not in a position to give you all the details about it. In our next briefing, we'll be able to give you that. I think the issue of the ventilators has also been mentioned. There's always a challenge here. Right now, we've only got about 55 people who are in hospital admissions. Although we've got 1,300, but people who have got who are in treatment within hospital, not a very large number. So what is important for us is to say we're dealing with the situation as it stands now. Now, sometimes when you get asked a question about future, it's a bit difficult to know. We will not cause you to misunderstand what we're saying. So we sometimes make a broad categorization as to what kind of projections you could be expecting, which are not specific for South Africa, which are just generic. And then, of course, the headlines is like so many people are going to be infected. So the misunderstanding becomes a bit of a worry to us. So I've now tried to stay away from, unless we're going to sit down and break it down, I want to stay away from too many projections, as it were. I can just say largely that we have understanding that from public sector, private sector, we should be able to utilize whatever resources and beds that are available. So we'll continue to work on that basis. And so we are also increasing the numbers of beds. Whatever number we can give you today, we're saying they must try and increase so that next time we should actually be increasing. That is really when we talk about more beds beyond what we've actually been talking about in the specific dedicated hospitals. So broadly, we've got over 87,000 beds in the public sector, and those beds, as much as will be necessary, we will actually share some of those beds and make them available. But we're also saying, because we're anticipating that the numbers might increase, we'll also be building up another set of beds. And that's why I was giving estimations as to what guidance we're giving to the provinces. But it's largely, indication of where we should go. And so I don't want any province to be tied up to say, tell us how many beds have you got, because we're not there yet. Right now, we don't have any pressure of beds. Right now, we don't have a crisis. We're dealing with the situation. But as we deal with the situation, we're now preparing. So sometimes we stop focusing on what we have. We focus on what might go wrong. And that is fair, but it's also important to just keep a balance so that whilst we're looking into the future, we mustn't confuse you to actually think that that's what we're dealing with. Yes, we are actually needing to increase the numbers of beds, and therefore it will be easier to deal with them when we say, okay, so many of them have been used up, so many new beds, and so much of additional beds beyond what capacity that we've got in the various hospitals. There is an issue about ventilators. Right now, they are adequate. However, we've actually heard that there were some companies that have actually offered to manufacture more ventilators. We've actually welcomed that, and we also said that we need to keep ventilators in reserve so that in case we need more, we actually have got more. We can't start saying, please go manufacture them when we run into a problem at that time. So it's all forward planning. It's not so much that we are saying that right now we've got a crisis of ventilators. We don't yet have it, but then we want to ask that these must be prepared. We have had a discussion with a number of manufacturers, and this work is being done. In fact, it wasn't just even myself who was talking about it. Minister Patel was discussing it, because together we sit and talk to the private sector involved in the whole value chain on the health manufacturing, pharmaceutical supplies, and medical devices. So, worst case scenario, what's the worst case scenario? Look, we have given you broad, the numbers that Dr. Masuku spoke about are just broad and generic. There's a team that's currently working on the modeling as well. They've done a bit of modeling for the next 3 weeks. And in terms of the figures that they've indicated, they've not focused on the admissions. They're focused on what the positive tests should be. In terms of those figures, for example, they would have anticipated that by the 2nd of April, we could be around, maybe between 4,000 and 6,000. And then by the 2nd, but if there was no lockdown, that figure could have gone up to maybe 7,000. And then it goes up, so that maybe in about 3 weeks, they would have anticipated that we could have gone to maybe as far as 16,000 by that time. But because of the lockdown, the figures are completely different from that. But you see, it's very early days. Because it's early days and there's also a lockdown, your modeling is bound to be distorted. And in this case, we're just looking at it and are saying to ourselves, you push us to answer questions of things that are not necessarily practical as we speak. And that we have to just do it simply because we don't want you to create an impression that there's something that we're not really looking at. But we are saying that at the moment, the numbers are what we have given, and they are not anywhere closer to where they could have been if there had not been any intervention, and that's the point we're making. But we're saying no one must take that and be complacent, because there will not be a warning when the situation changes. So we must always be having our foot on the pedal, be aware that all the time there must be action, so that we must affect and influence the way those numbers are going through. So a question is being asked about all the question, the medicine. We're going to be part of the the global effort on what is called solidarity trials. We did release a statement, if any of you may not have noticed that we did release a statement that they will be participating in trials. One trial will involve remdesivir, that's the one drug which is antiviral. Then the other group will be using chloroquine or hydroxychloroquine, that you know the drug that's being used for malaria and rheumatoid conditions. And then the other one is lopinavir with ritonavir. Again, those are antiretroviral, are used on HIV. But then in the other one is they will be using lopinavir with ritonavir plus interferon. Now, you've heard people talk about this interferon. That's all trial stuff. It's all about clinical trials. Interferon is something that we've got in the country. There are different formulations of interferon, and in this case, this one is being used for autoimmune disorders, and in some instances for oncology. So these are just the part of the broad combination of activities that we as South Africans will be involved in, and in some cases will also be involved in the vaccine trials. So all of this we're going to be participating in as South Africa, as it were. But by the time we get to the other side, we want South Africa to have been able to defeat COVID-19. We want to be able to have limited the numbers of people who would have been sick or died of COVID-19, but we must also be able to add to the global body of knowledge on this virus and other viruses and other diseases. So we want to be part of that whole global effort. So whatever we are doing, we're doing it in our best and earnest effort to make sure that we do the best for the country and also for humanity in general. Thank you very much.
All right, coming out of that media briefing there in Sandringham here in Johannesburg, Dr. Zweli Mkhize, the health minister, bringing us up to speed with the confirmed number of cases in the country, 1,380. That's up from 27 yesterday. And
the point of the worst case scenario is we should rather turn the question around and say, how well are we doing to prevent the worst case scenario, and where are we on the road? Because there's no point putting out a worst-case scenario as if nothing was being done in the country. And I think that starts to become a bit misleading. Usually the minister is the one who's standing here and he's speaking and answering all your questions. And I just wanted to say from the health community to acknowledge his extraordinary leadership at this time, the honesty with which he's addressing the questions and the issues, the communication that he's providing, and in general, the overarching strategy that's unfolding. Also, as chairperson of the board and on behalf of our board of the National Health Laboratory Service, we wanted to acknowledge the amazing effort by our team, led by our CEO, Dr. Kami Chetty. The NHLS comprises more than 200 laboratories across the country. But we also have the staff of the National Institute for Communicable Diseases and also the National Institute for Occupational Health playing a key role. And you can see how we've geared up. Remember that at the beginning of February, there were no tests globally available, test kits. We developed a local test in the country that we were using, and we're now gearing up incredibly fast to get to a point of being able to do 30,000 tests a day during the month of April. So I wanted to recognize that. I think the National Health Laboratory Service does 80% of all laboratory and pathology tests in the country. Our mandate as a public entity is to provide healthcare for the nation, to provide laboratory and pathology services for the nation. That's our mandate, and we seek to do that for COVID as well. So our aim is to be able to deliver 80% and more of all the tests that our country needs. In this regard, many of you will know that over the past 3 years, we've strengthened the National Health Laboratory Service and put it in a very strong position where we are now able to upfront fund 2 billion rands worth of expenditure as required to meet our responsibilities in this epidemic, or the pandemic, and that's our job, is to forward fund 2 billion rands worth of costs of setting up the capacity to deliver on our mandate to the country, and we'll worry about the payment as it unfolds. We're not going to stop and say pay first and then we'll deliver. We'll deliver because that's our mandate to the country. I just wanted to maybe just say, those of you interested in the issues of the taxi industry, you can find evidence-based guidelines in the College of Medicine of South Africa website. And just a last word to fellow South Africans, people living with HIV. If you are not on treatment, please get to your health services as soon as possible and get onto treatment, restart your treatment, but make sure you're safe. Thank you very much.
Thank you, colleagues. Thank you, Minister. Thank you to the panel, and that concludes this press briefing. Thank you.